to you this afternoon, achieving SDGs, the role of the second generation CHWs. You've already, heard a little about the Millennium Promise Alliance, and I'm going to share with you some briefs about the initiative that we have done in Ghana, zero in on the Community Health Worker Initiative by the 1 Million campaign, and then give you a brief about how we got to where we have gotten to, and then give you an outlook for our 2017, which will include the introduction of the first generation community health volunteers, and now the introduction of the second generation community health workers. So we have a very simple mission of advancing sustainable development in rural communities using innovative ideas. I must say that in a country with a population of about 27 million in Ghana, we have a mobile penetration rate of 128%. That's about 35 million mobile phone penetration in Ghana, which simply means that everybody, even yet unborn, are supposed to have phones. But I'm a very good example of why we have 35 million, because I have 3 phones. And I hide one each time I travel and keep 2. Simply because back home in Ghana, I have to use 3 because the networks are not stable. And so I have to make sure that as a field worker, I'm always online to respond to emergencies. And so we believe in mobilizing cutting-edge science and technology to effective local development agenda and pursue it with the people's active involvement. Today, we've been able to build on such innovative ideas to implement the SDG, global idea and goal in all the implementing zones and countries where we find our presence. And it has led to good results, where most of the interventions we introduce are all going to scale. I just told you about the community health worker, which is now being adopted at the UN level. The UNAIDS has adopted it. You can check it. And the AU has also adopted it. It started very small, and now it has gotten to the global level. We are present in about 20 different countries, and the lists are there for you to see, but I'm presenting to you here today what is happening in Ghana. But for Millennium Promise, we have presence in 20 different countries, and we believe we want to add on to that list. So the initiatives in Ghana include the Millennium Villages Project, where we were able to establish one district in Ashanti region called Bonsaso in Amansia West, where we visited with a team that came from Duke. And then we have another one in the Savannah zone, which is called Sada, the northern part of Ghana. We also have 3 different districts having putting in place the initiative of what we call the Millennium Villages Project. We also have the telemedicine, which you just saw in the video, and we also put in place the MySukoso project. We also have the Tropical Lab, which you also saw, and now growing our community health worker campaign from Ghana and beyond. So a little brief about the Bonsaso sites. What we did was we targeted only 30 rural communities with a population size of about 30,000, and that forms about 22% of the district population and a third of the size. And it's a forest zone. We went through the forest, and the pictures you saw are actually coming from that part. It's a forest zone. But when we went to the north, we decided to tackle 3 districts, and we identified 35 communities where we did this work. And that one also had 30,000 people. Now, these are some of the interventions that we packaged in each of the communities that we implemented. We had health, education, agribusiness, water and sanitation, community development programs, and infrastructural program. And all of these interventions we actually did with the active involvement of the government for sustainability's sake. We believe in knowledge sharing, and so we believe in making sure that we rope them in at the beginning to allow for them to learn as we progress, and then once we are left, they can continue with the concepts. So these are some of the few things that we were able to do. We built some CHWS compound. When we say a CHWS compound, it is community-based health planning services. And it is the last lap in terms of the health structure in Ghana. You know, we have the regional level, which is a big hospital, a tertiary type, and a teaching hospital. We have, when you go beyond that, we have a district. And at the district level, we have the district hospital. You go below that, we have the sub-district, and that one is a health facility. Then you go below that, we want to make sure that we get closer to the people. And that one is a CHWS zone, where we plant what we call a CHWS compound to allow for the people to be able to access healthcare. So we did that, and then we also recruited and then put in place some equipment at the clinic level. We introduced the telemedicine. We added an ambulance to the telemedicine to allow for referral to be very smooth. So we don't just give you the call, pick the call, or give you directive as to what to do. We also provide the mobility to be able to transport any case to transfer to the next level. And then we have the community health nurse, a motorbike, so that she's able to travel the distance to the places where it's so difficult to go. And then we have the community health worker. These are the interventions that we put in place. We also introduced what we call the Embrace Net Warmers, where we try to keep babies safe. Even if they are born with underweight, we try to keep them warm so that they can survive. We also did educational programs introducing the school feeding program to retain students as school children and make sure that they are given at least one hot meal in the course of the day, because sometimes it's difficult. Just a meal to come by it is difficult in those parts. So it was very important we did that. Under the WASH program, what we did was we actually created these reservoirs that you see over there. And then we also did public standpipes, because drinking water is a major issue and can be a major source of many outbreaks. So we dug wells and with mechanized boreholes to support the community. And we donated a lot of equipment for sanitation purposes for them to do cleanup exercises. And we did what we call household latrine, because latrines are very, very important in that part of the world. Unlike here where everybody has it in their homes, it's not like that back home in Ghana and other parts of Africa. So we saw these interventions are very needful things to do, and we also came up with what we call the multiple seat toilets in community and schools to allow for them to have, you know, you are eating, so I won't bore you with those ones, sorry. Now we did some agribusiness also. I mean, development is very broad. Health thrives on all of these things being well activated. And so we taught the people how to do proper farming. And then we did what we call farmer field schools. The farmers, most of them are illiterates. And so we decided that we needed to go closer to them to ensure that we train them even on the farm, give them some appreciable literacy, adult literacy courses to allow for them to know exactly what it is that they are in for. We did we taught them how to dry cocoa beans and oil fruits and all of that. And then we introduced agric extension agents also. Now I come to the community health workers campaign. The whole idea is to accelerate the attainment of universal health coverage in rural sub-Saharan Africa by supporting governments and other agencies to be able to do tailor-specific ways by which they can deploy lower-level cadre of community health workers to advance care to the doorsteps of the people. That is trying to do what we call the universal health coverage. We can't meet it without the active involvement of these lower cadre of people, well-equipped, well-resourced, well-trained, and given the responsibility to deliver certain quality of services. Now I tell you about the first generation. We used to have, in Ghana, we introduced the community-based health planning services in 2001. And with that strategy, we had community health nurses deployed to the CHWs compound that I showed you in the picture, very close to the people in the communities. And they lived there, and they were taking charge of a population size of about 5,000. And with this population size, it was obvious that they would be overwhelmed with work. What happened was that they were very frustrated because they wake up in the morning and the whole corridor and the frontage of the house is filled with people with their chairs sitting outside waiting to be attended to. They are waiting for you. You can't bypass them to go to the house. They have come to you. Can you leave them? No. And so it became very difficult to achieve the noble objective of trying to put healthcare at the doorstep of the people, where we have one person is to 5,000 and expecting that person to be able to visit everybody in the household. A whole year will go by and 1 or 2 or 3 or more people would not have seen this health worker. They added what we call the layer, the health volunteers. Now, as the name connotes, I'm a volunteer. So I volunteer when I have the time. You can't compel me to do whatever you want. I do it at my own will. And that is the first generation health worker that we had. So this is the CHWs system as we want it. Mobilize community, with active community health management committee members. I want you to look at it carefully. We want to make sure that the community is involved. That is why we are saying it's community-based health planning services. Active community health management committee. The committee is made up of people who are in high position, opinion leaders, religious leaders, who matter, who can help mobilize the community. Then putting in place a strong referral system, and that is our CHWs compound in the middle, with a lonely CHO there, taking care of the population size of 5,000 people in the entire community. Now the community, the first generation of community health worker, who is the volunteer, is attached to this team. And what does he do? He's supposed to be in charge of what we call the, he's supposed to be in charge of HIV, one person, HIV, another person to be in charge of tuberculosis, another person to be in charge of malaria, another person in charge of pneumonia. We had multiple people playing that role of volunteer because they are volunteers and you can't overload them. And don't forget, they are not trained properly to do any particular work except for the malaria work. So just imagine that we have a volunteer come to your house, then he wants to engage you, and then you ask him a question on maternal and child health. He tell you, no, I'm only malaria person, so wait for a maternal and child health volunteer to come to your house to address your issue. It was just ineffective. We have multiple programs, no proper records. Volunteer fatigue began to set in because they thought that they were wasting their time and the other colleagues are being paid and they are not being paid, and they started grumbling. Multiple trainings. Malaria will go in and do his own training. Wasting of resources. TB will also go back to the same community, hide the center and do the training. And the people were just being frustrated. And the last thing was that this was inconsistent because malaria has its own funding and can pay so much in terms of transportation, no standardization, and therefore, if I don't have the money to pay the volunteer. They'll come and attend my session, but they'll go without doing the work because you didn't pay me like malaria did. And so it created problems. So this is the second generation that we want to introduce. Making sure that we consolidate all of these in one person. Because the nurses do that. The public health practitioners do that. The community health nurse at the community level who was a lonely person is doing that. So why can't we clone somebody to be able to support the community health nurse? So we brought in this concept of collapsing all of these volunteers into one integrated community health worker who is empowered to deliver quality health care at the doorsteps of the people. And this person must be paid, must be well-resourced, and must be remunerated to allow for that person to be able to deliver. He must be accountable and responsive. So in 2013, we had opportunity to partner with the Youth Employment Agency of Ghana to deploy this cadre in Ghana. So I call them the 2G community health workers. I know we are behind time because we have 4G and, but we are going slow. We are going very slow. We don't want to rush. 2G, the second generation community health workers. Now they have been introduced. And I believe that they present a very strong frontline cadre who can rapidly tackle disease prevention, health promotion, maternal and child mortality issues, family planning uptake, comprehensive household registration, and real-time electronic data collection. To enable us to do this, we had to engage certain stakeholders. So, we engaged the Office of the President to ensure that we have the political will and the financial commitment. As I speak to you, Ghana commits 1.5 million every month to the payment of these community health workers. Initially, they would have told you we don't have that funds. But when they saw where your treasure is, your heart is. Isn't that so? When they saw the need to save their lives and the need to create some efficiency in the system, they saw that we can actually get this done with our domestic resources. And so they decided to use the talk tax. So me, I'm paying more because I have 3 mobile phones. And I make calls and they deduct it to pay the community health workers. And it's very sustainable. It's gone to the parliament, they've approved it, and that is what we are rolling out. And we needed also the Ministry of Health, Ministry of Employment and Labor Relations, Ministry of Local Government, and the Parliament to ensure that they all understand and have a stake in this. And this created a very good enabling environment in terms of the policy, in terms of the technical component, and also making sure that we have an oversight responsibility over the work that the community health workers are supposed to do. I'm talking about the second generation community health workers. They are more responsive, real-time result-oriented, very capable, and are now equipped and skilled to be able to support systems. So we engage all these stakeholders you see here, and they all have a stake. And how we did that was to make sure that we made them to understand how they can leverage on their SDG-related goals to achieve this. So we started off by creating a curriculum that can actually train this community health worker in a manner that will be holistic and well integrated and harmonized. So we needed to collect all the materials that they have been using in country to train the malaria people, the TB people, the HIV people, create a repository, and then set a team together to bring all of these materials together into one curriculum that we can use to train them. And World Vision International supported Ghana to get this done. So now we have a national curriculum for the community health worker cadre. So we did a training in a very fast manner, but very comprehensive training. We also developed what we call an implementation guidelines that supports the deployment and the recruitment, the placement, and all of that. Now, the community health workers that I'm describing are indigents of the respective communities. And they are people who understand and know the community where they come from and where they reside. And they speak the local language. And so they are able to engage properly with the people. And these are people who are high school level people. They have gone to school to the secondary level. And we believe that it is going to give us the opportunity to whip up their interest to want to take up professional training in health so that they can stay back in their communities to do the work. We did this because back home in Ghana, it's so difficult to get a doctor who has gone to all the school with all the fine things with his car and post him to that part where the car cannot go. You know, he won't go. To have a nurse who has gone through all the training and ask that nurse to go to the place where water is so much of a problem. Electricity is a problem. He won't go. But when you have a native of the land who is already there, he hasn't gone anywhere. This is where she's brought up. She also deserves health care, and we have given that person the power and the opportunity to serve their own people. I'm telling you, they take it with both hands, they receive the training, and they deliver because they know they are committed to their own. And that is the second generation community health workers. We did this implementation guidelines, making sure that the Ministry of Health, the Ghana Health Service, the Youth Employment Agency, the nursing training institutions, the National Association of Community Health Officers, NGOs, and all who had a stake in what we're supposed to do contributed to the implementation guideline so that everybody has a stake in it and are committed to making sure that we succeed. Now I told you about how I did the trick of getting all of them to come to the table. Because, you know, I'm sure it's also here where the health sector will think that I have to concentrate on my corner and do my health stuff. The labor people will concentrate on labor issues and the likes. No, we told them, look, we need to come together. You are Ministry of Employment and Labor Relations. You are interested in creating jobs. Come, we want to create some jobs, and we are not in charge of that. You are in charge of that. Would you mind joining us so that you spend a little of your budget on the workforce that we need to make sure we advance healthcare? They came in. That is SDG 8, job creation. Now we said Ministry of Health, yes, you are in charge of our health service. Now we have new goals. We need to extend healthcare. We want to achieve universal health coverage. You can't just be sitting at the hospital doing damage control when people are not able to take good care of their lives. Then you term that as health. Health belongs to the people. Let's send healthcare down to the people and let them take charge of their health, own it, and when they are not successful, they can come to you. That way you will do your work. But you need to change your focus. There must be a paradigm shift. Let's join forces to do this. That is strengthening and making sure that we achieve SDG 3. Then Ministry of Gender. Yes, I had a very nice case for them. That going to the household, I needed more women. More women. Once we train them and give them that opportunity to go to the household and they take up that challenge, going forward they would want to take up professional training and nobody can abuse them. They'll be quite knowledgeable and be in influential position to advance the cause. Why don't you come on board? They were quite excited. And they joined. Hello? Do I have some ladies in the house? Right, so we did that. And fortunately, we had about 65% of the community health workers being ladies, so that we'll be able to advance that cause. We had internal migration issue also with the Ministry of Labor, Ministry of Local Government. People move from the northern part of Ghana, coming down south to do head porter job. Head porter is like coming to the market, and when you buy your stuff, they say, can I carry it for you so that you pay me? And where they sleep, you can Google it, check it. The name is there, Kayaye in Ghana, and you get it. Head porters in Ghana, check it up and then you cry. They sleep on the streets, people abuse them anyhow. This might be a good way of retaining them in their respective communities by engaging them this way, so that they don't come down south looking for jobs that do not exist. Are you interested? Come on board. Creating jobs. and making sure that we address the issue of migration, SDG 5. Then we got the skill acquisition and capacity building issues with the youth employment. All of these are SDG related. Technology and making sure, all of these are SDG related. I won't bore you, but I will leave the slides behind for you to also have the opportunity to do some homework on them. Now we use this and we were able to advance our course of investing in the unique second generation community health workers. This time, well mobilized, well coordinated, well incentivized, well skilled, well equipped, trained, and paid to deliver on accountable tasks and targets. Now we believe that integrated, trained, and incentivized community health workers can increase the uptake of health services, can reduce health inequalities, can provide targeted and focused service deliveries. And when I say targeted and focused health deliveries, I mean when the community health worker has actually gone to the households and they are able to give you the record that shows that there are certain emerging diseases in this part. When you are going there, you go there prepared. Unlike the previous time when you had to go to the household, do all the paperwork. When the person is talking to you, you are busily writing, and so you don't even see. The eye contact is not there for you to examine, to assess, and to know that this person has a swollen feet or that and all of it, because you are busy writing and all of that. Now we are doing paperless system where you are using the mobile phone. So as soon as you ask the question, you tick, you ask the question, you tick, and by the time you finish, you have a report generated at the other end. And so we are able to do target-specific intervention going to address issues that are emerging in some parts of the community. It's also going to create sustainable, decent jobs and improve local economies. So supporting the health system, like I told you, this is the CHIPS compound. So we expect community health workers to be there. I left the shadow of the community health volunteers who are the first generation community health workers there, simply because I believe these people might want to move on to become a CHO one day. And therefore, once they move, easy replacement of this attrition will be the CHV, the first generation. And therefore, it becomes a reward system, upgrading system, recognition for these CHVs. Once you perform well, you can advance to this level. I'm still struggling with how to get a career progression for this cadre, but I believe we'll get there one day with your help. Now the CHO is here at the chief zone level, and she supervises the community health workers all over. Right? So we have, in every chief's compound now, we have a minimum of 2 community health officers. So what that means is that you'll be in charge of this set, and I will also be in charge of that set. Then at the next level, we have the referral level. So in case there is a feedback that is beyond you, you refer quickly. Then there is a nurse midwife at the next level, that's the sub-district level, to take care of any fallout from this end. Then we have at the district level, the referral hospital, a district hospital, that takes care of the high-level care that is required. So this is the description of the health system in Ghana, and this is how the community health workers fit in. This is what I am looking at, and this is what we have in Ghana. Now we have the teleconsultation center in the middle, the telemedicine you saw in the video. The telemedicine is simply like they described, where people refuse posting to. We have the community health workers who now have the mobile phones, smartphones, not just a mobile phone. Because back home in Ghana, we call the phones that are this size, that are not Android and fancy, we call them YAM. We call them YAM phones. But what they have are smartphones that are able to do the WhatsApps and all the SAPs, making sure they're able to do, So we have the teleconsultation center here. We have the higher level hospitals. It might be private, we don't care. If you do well, we can send cases to you. We have the District Health Management Center or the district office. We also have the sub-district level here, and we have the CHO with the CHW down here, and that is the community members. So a standby ambulance always on standby to make sure that in case there is a fallout, they move swiftly to the community to pick up the case and transport it to the nearest hospital that is required. That is the system that we have in place, and this is the Regional Health Center. The Regional Health Management Team, that's where they are. And so they all operate. This one oversees that one oversees this, and this one oversees that. And they can all have access to the central point. This is the description of how the CHWs interface with all the programs and the interventions that we have put in place. Now the role of the CHWs. The CHWs, the second generation community health workers, are supposed to register every household member in the community into a register that is electronic, to do health promotion and disease prevention, case detection and first aid management of minor ailments, and refer. They also undertake telemedicine activities and do some consultations at the household level. They do community mobilization and health education, and they do what we call a defaulter identification and referral. So when people default, like they go to the hospital, they are given some medication, they're supposed to, complete it. Once they leave the hospital, they drop it. These community health workers will follow up with you and find out, have you finished with your drugs? And where are you? And what, have you gone for your follow-up or your checkup and stuff like that? These are the work that the community health workers do. They also support with identifying defaulters in terms of immunization, making sure that those who do not come for immunization are identified and asked to do so. So back, we have 19,403 as at the beginning. Now we have 20,000 community health workers deployed in the whole country. We also have another cadre called the e-health technical assistants. The e-health technical assistants came about as a result of our interest in mHealth and data, real-time data using the digital means, where we want to ensure that data is transmitted in real time. And now we are introducing the community health officers and the community health workers to mobile phones. They are likely to encounter difficulties. They are used to just making calls, hello, how are you, and putting it down. Now they are asked to load reports and stuff like that. They may have challenges. We need people who will be there readily available to support them, to troubleshoot, and to do that, to fix it for them. And they work very closely with the district health information officers. And in Ghana, we have what we call the District Health Information Management System, which is the nationally approved platform where all our clinical data and interactive data are loaded onto. They meet. That's where they put it. That's our data hub for the health service. So we rolled out this cadre, and 1,000 of them were deployed in the country. Now, to allow us to achieve the good results to share, we decided to do a demonstration of this concept scientifically. Even though the country has gone to scale already, we wanted, the initial idea was to do a test of theory to see whether it is feasible, practicable, efficient, and cost-effective. And the government got too excited and decided to scale it up. But we didn't want to run along with that excitement. We wanted to still keep our eyes on the ball by making sure that the scientific component of it is not compromised. So we have 7 districts where we are testing scientifically how effective this whole approach is. And these are the 7: Amansia Central, Amansia West, Asokore. I'm trying to pronounce them for the first time so that you can have an idea. Asokore Mampong, Bosomefrahu, Edura Dumase, Central, Kumewu. These are the 7 districts where we are doing a pilot of this community health worker. But then we still have the upscale of 20,000 already. And to enable us to make sure that the electronic system is not compromised in terms of network connectivity and infrastructure issues and all of that, we decided to ensure that we do mapping, comprehensive mapping of all the districts where we are supposed to work in the communities. The mapping was to allow for us to be able to identify the signal strength of the respective telcos in Ghana, so that we will know the SIM card that we're supposed to give to a particular group of people in some part of Ghana, because it's not all the places that all the networks are very strong or effective. So we needed to do that. We needed to also map out all existing structures and facilities that can support the health system. The chemical sellers, the pharmaceuticals, the traditional birth attendants, and all those people, we needed to map them out. We needed to map out the CHWs compounds that are functional to allow for us to be able to know where to refer cases to and all of that. So that is what we meant by the mapping. And we also needed to have the GPS location of the houses where that is assigned to a particular community health worker. So we mapped that out and then enabled us to be able to give unique codes to every household within our treatment zone to allow for us to track. So you can't tell me that I've given you a mobile phone and you are lazy today, you don't want to go to work, so you sleep in your bed, and then you start testing because you know the name, the family head's name, and the people. So I went to see Melissa, I went to see Mary, and I went to see, we will catch you because it will show us you are in bed, you are in your house. Because we are expecting, once you go to Melissa's house, Melissa has a GPS location, you know we have that code already established in the system. And so the system will pop up and tell us that you're already in Melissa's house with a phone. So whatever data you are collecting there will automatically go under Melissa's name, you know. But if you stay in your house, it will go in your name, in your room, and so we can detect that this is faulty and it's wrong data that you want to send to us and can lead to your expulsion from the group. So we have actually done a baseline survey. We partnered with the research division of the Ghana Health Service and with the Kwame Nkrumah University of Science and Technology to do the research. The baseline is complete. Data analysis, as I speak to you, is still ongoing. And to allow for us to do this tracking properly, we developed a new platform called the C-Tracker. The C-Tracker is simply the community-based electronic tracking system that allows for us to track you so we can catch you when you do the wrong things, and we can also track and trace the defaulters and help to do proper due diligence. And this is to allow for proper supervision, spot check, and the likes. And we built on, the country already has the DIMS, like I told you, and we also used to work with Dimagi, which the platform was ComCare. I don't know if you know ComCare, but the ComCare was very good, but I had a major problem with the country where people didn't want to have anything to do with ComCare. Meanwhile, it was the best tool that we needed. They wanted to force us to use their system, which is eTracker. And I saw that eTracker can only give me aggregated and facility data. And I needed longitudinal data, that is a data that is able to go all the way down to the individual. And so we needed to build a hybrid of both the C-Tracker and the eTracker, the ComCare and the eTracker. And that's how come I arrived at C-Tracker as a platform to play it safe. But it is very good, I must tell you. It's helping us a lot to be able to have a very clear picture of what to expect and how to go about it. And I've already explained this. Now, we are implementing the telemedicine in the 7 demonstration districts of Ashanti and some part of Ghana. As I speak to you, we have scaled it up to the whole of Ashanti region, and there are 5 other regions that are coming on board now. We've been able to get the equipment for 4 of the regions, making it 5 now in Ghana. So halfway down, halfway to go. So telemedicine, as I speak to you, is now being scaled up to cover the entire country. And I would want to share with you the telemedicine model. You already saw it, And this is how it works. You make a case, and if it is beyond you, you transfer the call, you place a call to the next level. And if it is beyond that next level, they place a call to the teleconsultation center. And then the consultation center tries to stabilize the condition, help you to address it. And the consultation center is manned by people who are very experienced, midwives, nurses, who have practiced for long and know what they are about, emergency nurses. And there are standby specialists and doctors who are on standby to be called anytime such situation arises. So this is a pictorial view of practical things that happen with regards to the teleconsultation center. And like I told you, we have all of these regions having to start their telemedicine across the country. So this is the national scale-up. We are seeking to make sure that we deploy it in the northern part of Ghana, to have a telemedicine center there. The ideal thing is to have it in every regional capital. And they are to make sure that once they are there, they plug into all the districts and all the communities so that they are accessible. And the reason being that we want them to be able to speak to the people in local languages. And so we don't want to have a national telemedicine, but we want to decentralize it because we have different languages. And you may not know the terrain. If you are in Accra and somebody places a call from Bolga, you don't know the terrain to be able to refer the case because you don't have the map so readily available. But if you are within Bolga and you know the terrain, you understand the language, and you can do that. That's why we have decentralized the telemedicine model all the way down. So we had to give the community health workers, the CHWs, some phones. I was happy to have Randy and Mary come witness one such donation and training that was happening back home in Ghana. We've given the CHOs mobile phones, smartphones, I must say, and we've given the chiefs coordinators and the e-health technical assistants some tablets, and we have given laptops to the district health information officers to allow for easy synchronization and transmission of data. We provided them with all of these equipment and logistics. And in this bag, they have what we call some commodities, first aid and stuff like that. And these are the tablets and the laptops. And there's a jacket that I put on anytime I go to the field so that I'm easily identified. And I'm sure I'm going to give some of the Ghanaian, the team that are coming to Ghana, some jackets. You miss out. All right, so like I told you, we had a good partnership with the UNAIDS, making sure that they leverage on the experience that we have had to advance the 1990 campaign. And I must say we've learned a lot of lessons. Yes, we have very clear vision articulated in our National Community Health Worker Roadmap. We got the political commitment from the discussions at all levels. When the president got opportunity, we got opportunity to meet with the president and to share this with him. It landed us 20,000 with continuous care. And I must tell you that the commitment went beyond political lines because we had an election. In fact, I must say we had a very proud, beautiful election back home in Ghana. I've not said anything. I'm just talking about Ghana. We had a very proud, elections back home in Ghana, with a new president taking over with a new mindset. He came to inherit this. Typical African, typical Ghanaian, as I've known, would have told you, no, pack it, I have fresh ideas, otherwise these people will say that I came to steal and continue their ideas. I want to start my own idea. Give me a new concept and I'll run with it. Close this one and let's start a new chapter. But he didn't do that. He decided to continue because he said, this is very good. That is sustainable. That is what we mean by the goodwill, because we had the parliamentary approval and we had the support of both parties for scaling up and making sure we have this. We have multi-sectorial task force. We did a lot of advocacy and stakeholder engagement. You saw it, making sure that they have leverages in it to allow for them to be able to be part of it. And we made sure that we drew lines between the SDGs to allow for them to have connections and the rationale and reason to be part of this whole thing. And it's given us some milestones. Yes, we have the roadmap. 2014, we had the roadmap finalized. We had a CHW training manual developed. We had the CHW implementation guidelines done. We had baseline underway. We recruited and trained 20,000 community health workers plus 1,000 e-health technical assistants. In 2017, we developed what we call the tax sharing tool implementation guidelines that allows for us to be able to seed off some of the work that the CHOs are supposed to do down to the CHWs and allow the midwife to also seed off some of their work to the CHO to relieve them so that they can take up more responsibility. So we call it, on the global platform, they call it tax shifting, but we term it tax sharing to allow for people to understand that they are sharing for the purposes, the good purposes. Then we introduced the C tracker in that same year, 2017, rolling it out. So the way forward, creating the CHW Situation Room. The CHW work is on the ground, but I'm looking forward to the day where I will have a situation room where we tell the story of Ghana globally and electronically so that you don't need to travel to Ghana to see what is happening. You can click the button and you can follow whatever is happening. I call it CHW Situation Room. You can do same in Tanzania, Kenya, wherever we have CHW programs. And I'm looking forward to somebody who will be able to help us to flesh out that opportunity of creating CHW Situation Room for the accounting for the 2 million community health workers that the UN and the AU are talking about. You can take it up. Let's do it. Then I want to see a scale up on the e-health component. I want to see a visualized data. I want to have a visualized data where I term it hotspot mapping, where at a click of a button, you can see the disease trends mapped out and the danger signs easily popping out for you to see that, yeah, this is what is happening here. We need to go in fast before it becomes an epidemic. That is what we should be doing as public health practitioners. That's what you should be looking out for. We don't have to behave like, excuse me to say, our predecessors who were doctors and were waiting for people to fall sick and come to the hospital to come and receive treatment. The damage.